I'm going to talk about the first aspects to consider in lupus, which are the classification criteria and the activity and damage indices. First, regarding the classification criteria, this is the outline we will follow, starting with a very brief introduction to lupus. Then, a historical context, the definition of the criteria currently in use, and the summary algorithm included in the current EULAR recommendations. And some future considerations that are mentioned, and well, I thought it was relevant to bring them up in case they are of interest to any of you. As an introduction, we know that lupus is a systemic autoimmune disease, often considered the paradigm of systemic autoimmune diseases with its component of antibody and immune complex formation, which ultimately causes damage with very heterogeneous clinical manifestations, affecting a wide range of organs and domains differently in each patient. Therefore, for the rheumatologist, it can be a challenge, on the one hand, to establish the diagnosis based on symptoms that may seem compatible, and it is also a challenge to determine the degree of involvement and what type of treatment may be most optimal for each patient. That is why, over the years, various criteria, indices, and recommendations have been developed to try to clarify and address all these issues in the best possible way. Regarding the classification criteria for lupus, the earliest data date back to 1971 by the author Cohen, but it wasn't until 1982 that a scientific organization, in this case the ACR, reviewed and compiled all these criteria and created an initial classification of the first set of classification criteria, which they themselves later revised in 1997. And this, let's say, is the starting point of the so-called old criteria, in quotes, upon which later studies have been conducted comparing different sets of criteria, and on which the current criteria have been developed. These initial criteria had slightly low sensitivity, but they were quite simple. I'll leave the list here. I won't read them all, but there are 11 criteria, and the patient had to meet 4 of them at some point in the course of their illness. From that point on until 2012, they weren't updated. And finally, in 2012, let's say another scientific organization, SLICC, which we'll talk about later, the damage indices, reviewed and updated these criteria. What did it mainly add? Well, it aimed to give a bit more importance to the immunological concept of this disease. It still maintained the cutoff point that 4 criteria had to be met, but this time there were 17, 11 clinical criteria and 6 immunological criteria, requiring that the patient meet at least 1 criterion of each type, 1 clinical and 1 immunological. This was meant to emphasize that it is an immunological disease and to reflect the importance of that aspect. In terms of sensitivity and specificity, one improved while the other got worse. Now, the specificity was a little lower. Compared to the 1997 criteria, our starting point, what did the 2012 criteria add? They added more mucocutaneous clinical features, included lupus, the neuropsychiatric domain, added hypocomplementemia, and anti-beta-2 glycoprotein antibodies, because only the other 2 antiphospholipid antibodies from APS were included in the lab criteria, along with lupus nephritis as a sufficient criterion, as long as the patient had positive ANA or anti-DNA. Over the years, the SLIC criteria were the ones used up until around 2019, which is when EULAR ACR reviewed and once again revised these criteria. What was EULAR's focus, EULAR ACR, in this latest revision? Well, on one hand, it was to improve the specificity that had been lost with the SLICC criteria, and on the other hand, the novelty, or what prompted the change, was the attempt to include these newly diagnosed patients, the so-called early onset cases, which are patients with a lupus diagnosis of less than 1 year of progression. So, a series of reviews were carried out, expert panels were convened, comparisons were made between different sets. Overall, a complex process. But the 3 main changes made in these current criteria were the following. First of all, ANA went from being just another criterion to becoming an entry criterion. ANA are very sensitive, but not very specific. They are not specific to lupus. And in the end, even at a titer of 80, it was found to have a sensitivity of nearly 98%. And in the end, they found it more advantageous for it to be an entry criterion, and it also supported the inclusion of these newly diagnosed patients. On the other hand, they wanted to study this subgroup of patients and compare the clinical presentation they show versus that of the rest of the lupus patients, because ultimately for patients with a longer disease course, it's easier to see that they had developed more clinical symptoms, more organ involvement, and it's easier to fit them into certain criteria. But for those with a recent diagnosis, it was a bit more difficult and more tedious to assess what clinical features they had. And in fact, the only thing that came out significantly higher in this recently diagnosed subgroup was fever, so they tried to include it. And finally, they realized that obviously not all the criteria being assessed carry the same weight. So they grouped the clinical criteria, there were 21 in this latest review, into 11 domains, 7 clinical and 3 immunological, also assigning different scores within each domain based on the importance and severity of each clinical aspect. And on the other hand, they added some elements at the expense of removing others. They actually removed lymphopenia because it reduced specificity and it was more beneficial for them to eliminate it. They removed the Regan tests for syphilis because we know that in the past, many years ago, over the years, the laboratory tests used to detect antiphospholipid antibodies were somewhat more complex and intricate, and it was found that these antibodies cause a reaction, false positives, in this type of test. Initially, in the previous criteria, the reagent tests were included among the diagnostic criteria, but in this latest revision, they agreed that actually laboratories and laboratory techniques are now very reliable, allowing for accurate estimation of these antibodies, and it was no longer necessary to include the false positives from these tests. So then, as a brief summary, I'm not going to read absolutely everything, but I will leave you with the 7 clinical domains and the 3 immunological domains. As the first domain, we have the constitutional domain, which includes fever, defined as higher than 38.3 deciliters. Regarding the hematological domain, it includes leukopenia with a count below 4,000, thrombocytopenia with a count below 100,000, and autoimmune hemolysis, along with all the indicators that point to this type of condition. Regarding neuropsychiatric lupus, in order of severity, there is delirium, psychosis, and seizures, each with their respective definitions. As for mucocutaneous involvement, it was established that it could be considered valid whether observed during an in-person consultation or through moderately recent images provided by the patient, and it defines what non-scarring alopecia is, oral ulcers, as well as subacute cutaneous lupus and discoid lupus as chronic and more severe manifestations, and lastly, acute cutaneous lupus. Regarding serosal involvement, pleural effusion, and pericarditis. With respect to pericarditis, it mentioned different situations in which at least 2 of the following had to be met, but in general, serosal involvement. As for the musculoskeletal domain, which is important for us, the criteria required either that a patient present synovitis in 2 or more joints, which is understood as having effusion or swelling, or that they experience pain in 2 or more joints, but accompanied by morning stiffness lasting at least half an hour. And the last domain is renal involvement. At a lower threshold, this is defined as proteinuria of 0.5 grams in a 24-hour urine sample, and then it differentiates between lupus nephritis class 2 or class 5, and at a more severe level, class 3 and class 4. Regarding laboratory aspects, the 3 domains included antiphospholipid antibodies in all their current varieties. Complement levels do distinguish whether only one fraction or both are decreased. And as for lupus-specific antibodies, the ones actually included are anti-DNA and anti-SM. This is the algorithm they use as such. Sorry, I'm not sure if it might look a bit small, but anyway, this is exactly the excerpt from the recommendations. And the guidelines, just to recall a bit about the current criteria, require a positive ANA of at least 180 as an entry criterion. Obviously, other causes must be ruled out, mainly neoplastic or infectious ones. There must be at least one clinical criterion, because we can have positive ANAs, but if they're not accompanied by compatible clinical symptoms, those ANAs don't indicate lupus and may point to something else. Then, within what we previously referred to as a domain, if a patient meets several aspects within the same domain, only the most severe one, the one with the highest score, is taken into account. And the cutoff point to meet the classification criteria, which remember are for classification purposes, is a score equal to or greater than 10. And we emphasize, just as was the case with the 2012 SLICC criteria, where nephritis per se with certain antibodies was already a classification criterion, here class 3 to 4 nephritis is also by itself considered a criterion, knowing that They have to have ANA as an entry criterion. We know that here in this case, the same thing happens as with those of ISLIX, who have only maintained that lupus nephritis, in this case class 3 and class 4, is already in itself diagnostic, it is classifiable. As future considerations, they want to include in upcoming revisions, they mention the attempt to incorporate biomarkers. They list here some of the most relevant ones, but it's something that cannot be standardized across all laboratories. It can't be generalized. And so far, its study has remained somewhat limited. They also want to include, if possible, and further define the impact on newly diagnosed lupus cases, as well as promote the inclusion of latent lupus. And finally, they aim to expand these studies to include other ethnic groups, since they have observed that other ethnicities may have different profiles with different types of conditions that can influence and alter the weight assigned to each of the criteria.